Welcome everybody to the Mental Health Action Partnership learning session on emergency detention issues and effective practices. I'm Sita Deal. I'm the co-facilitator of the MHAP Criminal Justice Workgroup, along with my colleague Sunny Schneider. MHAP, just FYI, is a statewide community-led mental health coalition concerned with ongoing mental health system improvement throughout the state. We're very pleased to welcome our presenters today, and they'll describe collaboration that's going on in Rock and Waukesha counties to improve the emergency detention process. So I'm just going to, Julia, you can take down the slides for now, and I'm just going to give a little run of show for today. I'm going to give a brief introduction to MHAP and then describe the emergency detention issue just to lay some context for our session today. And then we're going to hear from our presenters and then take a few clarifying questions. And then we'll break into small groups to discuss what you've learned and what you're doing in your communities and the issues that you may be facing at the local level that remain unsolved. And then after the breakout group, we'll come together and highlight the main points. So I just want to emphasize that we really want to hear from you because we know that local players have been developing effective practices within the constraints of current law and resources. And so in your small groups, choose someone to take notes. I'm just having you think about this now. Think about what you might share because we're going to be gathering this information and we'll put it into a report that I'll talk about in a little bit. We are recording this session and we're going to share the recording and the notes and the slides and the handout with anyone who has registered. So Julia, could you put up the introduction slide on MHAP? MHAP is a broad, statewide, community-led coalition that's gathering to advance equitable access and continuous improvement of mental health care throughout Wisconsin. We look to the day when every person who needs mental health care will be able to access quality, affordable care in their community. MHAP has a number of work groups shown on this slide that are developing policy priorities to advance our vision. This is a learning session. This learning session focuses on one of those priorities. So MHAP, as I said, is community-led, but we work with state agencies and with the legislature and with local policymakers to make change. And our website is in the chat, and Julia's contact information is on the slide if you want to find out more about MHAP. Next slide. So let's talk about the problem that we're here to address. I'd like to start with the caveat that I'm just going to give you a simplistic description for context, and we recognize that there are many nuances to the issue, but just so that we're all kind of on the same page here, Chapter 51, Wisconsin's mental health law calls for a full range of services to address mental illness, developmental disabilities, and substance abuse. The law also calls for a unified system of prevention and services, and to protect civil liberties ensures care in the least restrictive alternative appropriate to the person's needs. That's directly from the law. However, although good work takes place every day throughout the state, Wisconsin's mental health system underutilizes prevention and early intervention. And then when mental health crises do emerge, our system relies heavily on law enforcement. Ideally, they're working in collaboration with county crisis workers, but not always, depending on where you are and what resources are available. And then if the person needs further care, they're often transported to an emergency room where there's a lengthy wait to determine whether the most appropriate care would be in a general hospital or a psychiatric or crisis stabilization facility or a psychiatric hospital, or whether they can be treated and released to the community. And then if the person poses an imminent risk of safety to themselves or others, and also refuses treatment, then they may be placed on a 72-hour involuntary hold and transported to a psychiatric hospital for evaluation and commitment proceedings. So all too often, This process leads to treatment in the most restrictive environment, that is Winnebago Mental Health Institute. That often involves a long ride in the back of a squad car, and when the person's case is heard by the court, for a number of reasons, the evidence may be inadequate to determine commitment, and the person then may be released with inadequate linkage to community services. So this process traumatizes the person and their family. It increases costs to counties. It increases the likelihood that people with recurrent crises will become involved in the criminal justice system. So the current situation serves no one well, but we don't agree on how to proceed with change at the state level. Next slide, Julie. So necessity being the mother of invention, players in local communities around the state have been gathering to address the problem, some of them for a very long time. In some communities, like those that we're going to hear about today, regular, transparent collaboration has led to effective case debriefing and data-driven improvements. We've collected some of these practices in a handout that will be shared at the end of the learning session today, and that cover crisis prevention and intervention and assessment, emergency room evaluation, civil commitment, criminal justice diversion, and facility discharge. So Julia, if you would take down the slides for a moment. So with that, I'm very pleased to introduce our presenters. I'm going to introduce them both, and then I'll ask Bette Trimble to start. So first, Bette Trimble is the program manager for Crisis Connections, Outpatient Services, Treatment Courts, and Prevention for the Rock County Human Services Department. She's going to discuss collaboration efforts in Rock County, including internal human services collaboration, and then law enforcement mental health flags, a crisis strategy information sheet, and community partner collaboration meetings. And then after her, Sunny Schneider, who works as a police officer in Pewaukee and Waukesha County, will talk. She's a U.S. Army Iraq War veteran, and she's currently enrolled in UW-Milwaukee in a dual master's program for healthcare and business administration. Previously, she worked as an officer for the Waukesha Police Department and was a foundational player in researching, creating, and implementing their crisis response unit, which follows the co-response model. And you'll hear all about that. Sunny's going to describe how Waukesha County came together, how they created data-driven practice, and developed low-cost solutions to improve mental health crisis response and emergency detention. So now let's turn it over to Bette. Tell us about the good work in Rock County. And go ahead, yes, slides, that's nice.
Okay, thank you, Sita, for inviting me to talk today. Julie, you can go to the first slide, if that would be great. Thank you. So for people, just as a context, Rock County, our human services is structured where all of our behavioral health programs, CCS, CSP, our outpatient clinic, are internal. We don't contract out for any of those services. So what I'm going to talk about here is kind of based on that, that we have access to each other in a way that maybe those programs don't in other counties. So several years ago, we identified, just as our CCS program grew, we just identified that the programs speak different languages, and they were struggling to collaborate together effectively for families and adults. And so we created a couple things to help with our internal collaboration processes. One of those things is our collaborative review panel, which we hold it every Wednesday from 8:30 to noon. The idea being that the panel consists of all the managers from our child welfare, youth justice, CLTS, and then all our behavioral health programs. And it's a place where staff, treatment teams from all those disciplines can come together, present the case, talk about the struggles they're having, and then the managers can kind of honestly cut through kind of some of the roadblocks that are there by talking about a triage into a program, talking about the need for maybe a behavior response plan that will support the family when they're experiencing crisis, just essentially open up the lines of communication and do some in the moment problem solving versus multiple team meetings, emails, things like that. So again, we do these on Wednesday mornings, and the staff, we have a whole process for how they request it. And so that's been really helpful in educating about each other's programs and just serving families in a more proactive way. You can go to the next slide, Julia. So then we also, again, along the lines of as our programs have grown, CCS and CLTS in particular, we just, again, found that staff were struggling to understand each other's programs, the policies they have to follow, the different languages that, you know, their statutes talk about and guide. And so we also identified and created some documents to walk staff through what each program is about, because like for me, I'm over crisis services, and we often run into staff from other programs who think that crisis is going to go mobile and help a family de-escalate a child in the moment. Or that they'll tell a family to call us, but we don't know that the family is going to call us or what's going on in that family system, which causes frustration when we don't know how to support them. So one of the documents we have outlines all the information about a program, what it does, what it doesn't do, and then the primary contact information. And then we also created a universal guide to collaboration, which is just kind of a step-by-step for staff who are new to the system, new to the profession, and who might just need some help establishing channels for collaboration, just as a skill set that they need to develop. And so that's been helpful. We train our new staff on this process, on both processes, as part of onboarding, and then periodically just resend the information so staff have it and keeping it in the forefront. You can do the next slide. Okay. So then our crisis services, and this is something we've expanded or the array of our crisis services, because for a long time it was primarily intervention and we had a small stabilization team. So our intervention team, you know, does all the things that people think of when they think of crisis intervention. But we also work to, in Rock County, we will support people who are also seeking voluntary if we've had contact with them. We also can provide funding for hospital stays for a voluntary individual to help them get the services that they need. We can do, our intervention team will do med prompts for people in our other programs to keep them supported in taking their medications, support calls, welfare checks, things like that. We do just, again, to I guess, take very seriously the part of Chapter 34 that says we should be working to divert from a crisis. We have 3 co-responder positions that with embedded workers within the Rock County Sheriff's Office, Janesville Police Department, and Beloit Police Department. Those co-responders remain Rock County employees so that we can use them flexibly. Bring them back to the unit if we need to. We often use them as a point person, somebody who's maybe struggling in the community but isn't ready for services or just isn't interested at that moment. They might just, those workers can create a relationship with those individuals to encourage them to get into services. We also have our stabilization team that is 3 crisis stabilization case managers who can provide intensive short-term services for individuals. Most often it's when somebody's coming out of the hospital, but we do also utilize them when we can to divert from that need. So they can help them get established with benefits, established with a provider. We have 2 prescribers that will do bridging prescribing services while somebody's getting linked to long-term services. And then we also utilize stabilization facilities. We have our Harper's Place, which is linked to directly to our crisis services. We also contract with Tularian Crisis Care Center in Madison, and we contract with the Mott Center for Youth Stabilization in Jefferson County. And then about 5 years ago, we took our behavioral health intake line and merged it into our crisis line, which is we renamed it our connections line, with the idea that so it's the same number. Somebody can call at 10 o'clock at night. They might not be in crisis, but they might be looking for mental health services or SED services. They can call our 5025 number, and they will always get a live person who will provide support, assess for immediate needs, and then make sure that that person gets linked with one of our connections team staff on the next business day in order to, again, divert from and get them linked to services so that they aren't utilizing the emergency departments or needing to go to the hospital. The connections team will work with anybody in the county that calls, even if they aren't seeking county services. So we will, somebody has insurance, they're struggling to identify a provider, the connections team will help them navigate their insurance, help them get linked to a provider, and provide support in that interim, doing linkage, just anything the person might need as far as support getting linked to services. We also have the room and board grant to support people who are seeking residential treatment for substance use. And so all of those calls go through that. And when we support somebody who's going to residential services, we have a staff who's assigned to follow that person through their residential treatment and make sure that the discharge plan is appropriate and is meeting the person's needs at that time. And if not, we work to do what we can to fill any gaps that might be present during that step down. We also have a dedicated, within the connections team, a dedicated behavioral health resource liaison who supports individuals with discharge planning, both for involuntary and voluntary placements if we're aware of that voluntary placement. So again, their sole job is to coordinate with hospitals, make sure the person's getting what they need. If there's a need for an internal referral to our services, they will do that, but they will also just make sure that if they're going to community providers, that linkage is there. Do they need anything while they're waiting for that linkage? Just, again, wrapping around as much as we can to make sure that they don't re-enter another period of crisis if we can avoid it. So next slide, Julia. So then our community collaborations include, we have a variety of meetings that we've put together in Rock County to make sure that we're just communicating and building relationships. And I guess if I could stress one thing, I think that's, for me, the basis and the key to all of this is we have relationships with our partners. So we have a behavioral health partners meeting that is once a month. Anybody providing mental health or substance use services in the county can attend, and it's really just a resource sharing forum. Sometimes, there's a specific person who's presenting about a new program, but it's really just a check-in. People share what events they have coming up, changes in their programming, and then those minutes are sent back out that can be shared then to, staff at the agencies that are there. We also attend, or I attend, our Rock County Law Enforcement Association meetings, which are often called our chiefs meetings. So it's just a place for me to meet with our district attorney also attends, corp counsel attends. And so it's to hear what's going on in the law enforcement world and also sharing what is happening in our world so that when they hear from their troops or their officers, X, Y, and Z is happening, they can be informed about it from that higher level. And then we do provide community Chapter 51 trainings as requested, because we want people to understand our process, the limit of 51, and just the idea of the complexities of it, because we acknowledge that, or we know that, when you have 51, law enforcement has their policies, their expectations, their rules. Hospitals have their policies, their rules, the things they need to follow, as do we in crisis. And the more we can educate people about the process, the better we can collaborate when we are in that heat of the moment in what can be very tense situations. And then we do have regular check-in meetings, both with our hospitals and our law enforcement agencies. Just they We had a period of time where we had a very structured one, and then through changes in staffing and that, they become a little more informal. And yet I would again say that it really is just about having key contacts in those agencies at the hospital that, for me or my supervisors, when we have a tense situation, we have a single person that we can contact to say, hey, this is going on. No finger pointing, no, whatever. What can we do to move this through? Here's what I have going on. Here's what you have going on. And just to sort through so that the residents, the clients, aren't getting caught in the middle of this complex system that we currently have. You can go to the next one, Julia. And then another initiative we did in Rock County through our evidence-based decision-making process to work very hard to avoid criminalizing people with mental health or substance use issues. We created a system where law enforcement officers are able to put a flag into Spillman, which is the law enforcement computer system where they communicate, that if they have contact with an individual who shares that they have mental health or substance use issues, they can put that into Spillman so that when the next officer has contact, they know that this person has self-identified, a diagnosis of bipolar disorder or maybe a trauma history. And it's very concise information, but it is just a little bit so they know they're going into a situation and don't misinterpret some behaviors as just being defiant or disorderly. We also have our crisis strategy information sheet. And this process is any resident or provider can use it's a very specific release of information that we developed that allows us to create the crisis strategy information sheet, which is really very simple. Who helps, what doesn't help, who we can contact, and it's concise information meant for law enforcement. So the individual and their provider develop it. If they don't have a provider, but they want one, they can work with one of my crisis staff to do that. And then that gets vetted to make sure that it's not overly complex or clinical, because law enforcement was very clear when we developed this. They want concrete examples of what they can do, not, as they said to me, my psychobabble. So like things like don't walk up behind this person because they have a trauma history, very simplistic things. Then that gets uploaded into Spillman so that, and gets flagged for law enforcement. So if they're responding, they have some concrete information that can help them hopefully de-escalate the situation and again, avoid that full-blown mental health crisis. You can do the next one, Julia. So the impact of these initiatives for us has been that our detention rate in 2021, we had 399 detentions. And in 2024, we had 231. And in 2025, I didn't get that added. We were down another 7. We were down to 224 detentions in 2025. Our institute admissions have been trending down. I did not get an updated for the end of 2025, but it's significantly less. We've also had a decrease in individuals who have repeated crisis contacts throughout the community. I think in part because of our increased efforts to get people linked and access to care through our connections line. And then just improve problem solving with our partners when situations arise. Again, very clear that we have strong relationships, and it's that everybody is trying to do the best they can in the moment. And we have a really difficult, complex statute to follow when we are trying to help people with mental health. So that's all I've got. You said go
Thanks
fast,
so much,
Sita.
Betty. Thank you. This is,
Yeah.
this is practical and common sense and impressive, and also based on, the principle of, that the person comes first and, their civil liberties should be protected and voluntary treatment is best, so it's based on all of those things and yet helps take through the process collaboratively. So thank you. So now I'm very pleased to introduce Sunny Schneider. And Sunny, can you talk about what's happening in Waukesha County? And I'm going to try to pin you and see if I can get it not to be too awkward here. Okay, so then there we go. Okay, go ahead, Sunny.
Sounds good. So just again, to reiterate the disclaimer, I am currently an officer with Pewaukee. I'm doing that part-time. However, I worked as a police officer for Waukesha City PD for 6.5 years. I only just left right at the end of January. And everything that I'm going to talk to you about today, I had a hand in being a part of. So good news is that when I'm done with this presentation, we are going to provide you with some folks at the hospital and at Waukesha County Crisis that would love to answer any follow-up questions as they're going to be taking this forward, going forward. So next slide. So back actually it started in 2021. I hadn't been a police officer for terribly long, and I was noticing an increase in mental health calls for our police department. And I don't think it's really any surprise. Most officers really don't appreciate mental health calls. When we think about becoming a police officer, that's kind of the last thing you think about having to go to. Right, we're not necessarily equipped with it, but here we are, having all these increased calls. By the time I left in January of this year, I'd say about half of our police calls on any given day had a mental health or crisis related component. So rather than fight this, how do we streamline and connect better and get better outcomes? Initially, this started from just a selfish, like, hey, police department would like some support here. What does that look like? So that is ultimately where the crisis response unit was born. My law enforcement partner, Jason Fink, and I did a lot of researching co-responder models where law enforcement rides with a clinician, in this case, county clinician, and we address mental health calls. So that's a model that's been out there for a long time. It's a great model. We felt that it was going to be most appropriate for a Waukesha City because of the frequency of calls, but also just the nature of the city and how close everything was. But in order to do this, right, we had to collect data. And I'm not just talking data for like crisis and beyond. I mean, like my police department bosses needed to see some real data. So you're going to be seeing some slides in a little bit that I created. And then we'll see how that kind of morphed into an amazing Waukesha County initiative for gathering more data from all police departments. In the beginning, again, before we had the formal crisis response unit, it just started with making a connection with one of the clinicians at County Crisis and saying, hey, this week we had 5 names pop up on our police calls, and a lot of them have severe mental illness or are just repeat contacts that we're experiencing as a police department. Like, how do we connect with you and get a better outcome here? And it was weekly meetings where we sat down and we just started talking about folks in an effort to divert from criminal behavior, to limit police contacts. And it was as simple as that. But kind of like you heard before with Rock County, communication is huge. I feel like so much of what you're going to see is when we speak and we work together, good things happen. When we isolate and we create silos, I don't care who you are, whether you're a police department or county crisis, bad things are happening. And ultimately that lands on the person in crisis that suffers the most from that. So you're going to see a theme there. And then the other thing I'm going to highlight today real quick is this amazing relationship with Waukesha Memorial Hospital that we were able to develop. Next slide. Next slide. So I'm going to go through these kind of quick. These are all my slides. Highly sophisticated police officer graphs. One of the things that we wanted to start doing is like, okay, what we have 5115s, just focusing on those that are taking 10 plus hours. What is going on here? Well, I started by looking at, I know people are going to different places, and I am not picking on Winnebago on this. So please, if anybody's from Winnebago, we're not picking on you. We realize that's a little bit different. But for us as a police department, this is where everybody was going. And you can see that even our local Waukesha County mental health was having some crazy long 5115 periods. It wasn't just Winnebago. Next slide. Then Jason and I were talking and we're like, we're probably having longer 5115 periods in the nighttime because nobody works 24/7. You don't have the same kind of supports 24/7. Well, in actuality, if you look at the far right column there for 5115s that took 10 plus hours, it's pretty darn spread out throughout the 24 hours. So that was actually very interesting to us. How do we, what do we do with this? Next slide. And again, these are all numbers from our police department. I don't know that it's very common for many police departments to collect their mental health data like this. So that is something that we found beneficial just as a department to work better with county and other folks. This slide here, what you're looking at is basically throughout the entire year. And these numbers are from 2022. For when we were first getting started, what time of day are we seeing 5115s happen? And this was going to help us figure out, well, when do we need a clinician here? We're not going to have clinician corresponding with us 24/7. We just don't have the resources for that. So when do they need to be here? And really we settled on from about 8 to 10 p.m. as the range. Next slide. And then this is the graph that really I give full kudos to making it very clear to all the community partners what is going on. So the darkest sliver there that's got a 2 in it, that is a 5115. There was 2 of them that took an hour. And I don't even know how that happened. That's a unicorn. That's a total freak thing. I think it's really more realistic to expect the 5115 from start to finish to take maybe 4 to 5 hours. But we had a couple that were on the very quick range. It could be that those were folks that were medically admitted to the hospital for additional medical concerns beyond just the psychiatric. But if you follow that circle to the very lightest section, you'll see the big old one that has got a 51 in it. We had 5115s in 2022 that took 10 plus hours. And that is ridiculous. That's ridiculous for the person in crisis, for the police officers, for the hospitals, for everybody. And when we showed this slide, our bosses were like, yeah, we got to do something. And when we showed this slide to county, they were like, oh yeah, we got to do something. Next slide. This is just to finalize within the police department. I had our IT guys create 2 reports. One is the non-crisis calls monthly, which is what you're looking at. And it basically totaled normal police calls. So, right, domestics, drug stop, anything that wasn't crisis related. On average, those calls take just over an hour in length of time. Okay, that's not too bad. Next slide. But our strictly speaking crisis calls can take an hour and a half. This is, you're seeing, so I brought you the most recent reports from 2025. That's these last 2 slides that you're looking at. So this is how good we've gotten it. Originally, when I ran this report that you're looking at, it was 3.5 hours. Our average crisis calls were 3.5 hours, not an hour and a half. So we've made some improvements. Next slide. So county, Waukesha County crisis. saw, the work that Jason and I were doing. They saw the partnership that we were creating, and they're like, you know what, we do have a problem with the 5115 length of time in particular. So they took it upon themselves to start collecting data from all the jurisdictions within Waukesha County. And this is now what you're looking at. If you notice the little slipper here to the right, it says results of 2024 ED time study. So what we wanted to do is really break down, Jason and I stressed, like, look, there's parts of the 5115 process that are really bogging the system, namely medical clearance, and then getting that person to the psychiatric facility. How do we improve this? Well, we wanted to track that with data so that we could really show this problem. And this is what county was able to do. They literally track different points, and we'll look at that closer here in a minute, but they were able to say, like, oh yeah, medical clearances on average are taking 3 hours. Why is that? And basically, once the person is medically cleared and they are going to that psychiatric facility or they've been accepted, that's taking 2.5 hours on average in 2024. What's up with that? Why is that happening? And they too started looking at, well, when people are going to Winnebago, does that make a difference? Here in our hometown, does that make a difference? So they were looking at all that. Next slide. So October is on the left of 2024, and then we've got December 2024 on the right. In just a few months of really tracking this thing, you can see we went from an average of 11 hours and 20 minutes in our entire start to finish 5115 process to approximately 9 hours, 9.5 hours. Okay. That's huge. We've made even more headway beyond that, but this just shows in just a couple months when people are paying attention to it and you're able to like clearly articulate with data what the pain points are or system breakdown points are, what good magic can happen. So if you're looking at this very closely, you'll see at the start, we measured this by when is that law enforcement officer first having contact with the person in crisis. Then there's a period where if they don't have a co-response, most places do not have co-responder units, the police officer has to do their own investigation and decide, am I calling crisis? Do I think I have criteria here for a chapter? Then there's calling crisis, right? The LE contacts crisis. You're reiterating what you have. Crisis is deciding, are they going to come? Then crisis has to drive to wherever you are, whether that's the hospital or that residence or whatever. That takes time. Then from there, they've got to do their own assessment. And that can take, on average, you can see that takes about an average of 55 minutes to an hour for crisis to do just that. Once the chapter is approved, we are going to the hospital to do medical clearance. In this example, you can see the average was 4 hours for October. 4-hour medical clearance. Okay. Then once they are medically cleared, placement to a facility was 2 hours and 50 minutes on average. All right. Then we've got them going to the psychiatric facility, transport, in other words, and their final destination. So this is some of the amazing, and I cannot give enough kudos to Waukesha County for doing this, and they are continuing to be innovative. I'm so proud of them. They have been wonderful community partners in really looking at this issue with their data. Next slide. So some no-cost solutions. Go next slide. So first thing, one of the very first things we did, and this was before we even had our co-responder, was the Waukesha Memorial Memo. Basically what it said is, you know what, if somebody in crisis is at the hospital, if they are not combative or actively trying to leave, why are you calling police officers to come evaluate them, right? You've already asked them what their story is, hospital staff, so they just did one traumatic telling of it. Now you want officers to come so they can repeat it a second time, when really it's crisis that is going to be making that determination outside of Milwaukee County, whether or not we chapter. Why are you involving police officers at all, unless we know for sure there's criteria and crisis wants to come and assess? And they're like, yeah, you're right. And crisis was like, yeah, you're right. That makes a lot of sense. So they cut law enforcement out as the middleman in this. Unless, like I said, if there's emergency issues, like with safety, fine, we're coming right away. But basically, we encouraged hospital, you should be calling crisis and figure it out, and then let law enforcement know if we need to respond or not. And it's been amazing. This cut down our calls by about 2/3 with the hospital. So great. Next slide. This is another example I had written. We needed to train our dispatch on this memo. So this is just a sample of what it looks like. Decision-making tool for dispatch when the call comes in. Waukesha City has their own dispatch. So if anybody's confused by that, we don't use the local county dispatch. Next slide. And then some other collaboration. So with the co-response unit that we had, we, much like Rock County, we had flag notifications. So shot order pickups. We'd have somebody that, let's say, is bipolar, they're off their meds, they're very reactive in the community, basically being disorderly. The public is calling the police department saying Sally's out there being disorderly. We typically would show up and arrest her. Well, if we know that she has a shot order that she has missed, which is typically shared with sheriff's department, we could have gotten her shot. Take her over to get her shot rather than take her to jail. So this is a really easy way to minimize criminalizing people. Same thing with when people are revocated or if there's a capias in the system, just share the communication. This information already goes to local sheriff's department, but local police jurisdictions who have day-to-day contacts with these folks weren't getting it. And why? Why is that? There's no good reason. So we fixed it by communicating together. Next slide. Impaired judgment. So we recognize that there needs to be better education around impaired judgment for law enforcement, but really in general, everybody. So this is something that we had looked at. Next slide. And then the next few slides, and then I'm done here, is just these are examples of what our Waukesha Memorial Hospital put together. They recognize with their staff, there's so many people that they need to train in and out. How do they create clear training tools for them based on what our collaborations once a month we're coming up with? So if as a police department we're saying like, hey, I showed up and the nurse really didn't even know what to do with the chapter 55, which was what was happening in this case, these charts really help train their staff better and just get on the same page. Next slide. Again, this is a flow chart that Waukesha Memorial came up for regarding that memo that you saw. Next slide. And then we also, the last thing that we're really working on is piloting an expedited medical clearance with our Waukesha County Mental Health. So between our hospital with our local Waukesha County Mental Health, and this has been amazing. They've been able to decrease chapters significantly. Next slide. Okay, so there's me, and now I put Lauren's information. Lauren is the Crisis Intervention Services coordinator for Waukesha County. She couldn't be here with me today, but she is the woman to contact for any of that amazing data stuff you saw with Waukesha County. So thank you.
Thanks, everyone. Julia, could you take down the slides for a minute? Oh, we're going to unpin Sunny. Okay, everyone, we'll take just a minute or two for some clarifying questions. So one question was, any measures that Rock County or Waukesha County took to cover themselves regarding confidentiality and HIPAA? And I'm thinking, Betty, that that your crisis screen only included non-HIPAA related information, correct?
Yeah, the other follow-up meetings, we talk more about, we don't talk about specific clients, we talk about general processes. There may be an acknowledgement of a particular situation or case, but we aren't sharing HIPAA information about what happened after when the person went to the hospital, things like that. So it's kind of like everybody who's talking about it is aware of the situation, and we just talk about it in very general terms.
Thank you. And Sunny, any thoughts about confidentiality and the information sharing that goes on in Waukesha?
Yeah, I mean, because we have the co-response, basically when we're operating as a co-responder team and we go to a crisis call, it's a crisis call. So crisis, we're able to kind of hear, right? HIPAA doesn't apply. And then as an officer, I'm just taking really good notes as I'm privileged to that in the moment for my folks after the call to share with the department, just so that we're all on the same page. Otherwise, the clinicians are very good about not violating any of that unless there's a true like crisis in the moment call that we're responding to.
Great. Thank you very much.
Can I ask a follow-up question?
Go ahead.
So I posted that question originally in the chat, and sorry, I had to step away for a bit because I'm playing both receptionist and manager today.
No
But
worries.
a question that I had was, I thought in Rock County you talked about having like a system where they could flag mental health patients in Spillman. And so how do you deal with confidentiality with that? Because I'm assuming that happens before a crisis situation occurs.
No, it can happen at any point. We've had outpatient providers who send one over. We have to periodically kind of like remind the community that this is available. And there's a very specific release that we developed with, and in this group that did that, our Rock County NAMI was present. We had lived experience of individual there. So everything was vetted, and it's a very specific release that allows us to only release the information that's on that crisis strategy information sheet. And one thing I didn't say is if an individual at some point doesn't want that information in Spillman any longer, the process we came up with is we upload a blank one. Because much like when we release records, a hospital sends me records, the person can't say, well, I want you to send those back to the hospital. So we just put it in that it's a blank one for that.
Thanks, Betty. And then there was another question about medical clearance, which is the process by which a hospital, an emergency room, determines where they can send somebody. So if somebody has, kidney failure, they're not going to send them to a psychiatric hospital because the psychiatric hospital doesn't have the capacity to treat that. So that's what the medical process is. And somebody very helpfully put, a list of some of the tests that need to be done in order to perform medical clearance. But the problem is that it's not consistent, and then often there are additional tests, which adds additional time. So medical clearance is a necessary process, but we can make it more efficient. I think that's the point. So now I would like to, Julia, go ahead and put up the slides about the breakout groups. Again, we really want to hear from you because we know that you've been grappling with these problems and have come up with solutions that may be valuable to other communities. So Julia is going to open the breakout groups in a moment. Please choose someone quickly to take notes, and then here are the questions we want you to discuss. What did you hear from the presenters that would be useful in your community? And then what else are you doing in your community that's effective to reduce the need for emergency detention, or when necessary to make it go more smoothly? And then what are the persistent emergency detention issues in your community that you have yet to resolve? There's only going to be time to discuss a few ideas in the whole group afterward, but we'd like you to put the main points in the chat once we get back together. And then we'll collect all of these ideas. And as I said, we're producing a report that we'll release in the spring, and we're collecting a lot of these ideas. We would like you to, if you put an idea in, put the place and hopefully a contact person so we can follow up and include it in the report. So, okay, you've got 20 minutes. We're going to get back together at 3:40 to talk as a whole group. And go ahead, Julia, and open the small groups. And you have to press the blue join button. Okay, so before we launch into the hearing from the small groups, does anybody have additional questions for Sunny or Betty based on your discussion? I see one in the chat. Oh, this is from Sunny.
No, yeah, not a question. It's not a question. It's just our summary of our points that we came up with.
Okay. Any questions for Sunny or Betty before we go into hearing from the small groups? Mary Kay.
Briefly, I thought this was an excellent question. Both Sunny and Betty, it was brought up, loved the communication you guys are doing. Everybody seemed to be very impressed with what you guys are doing. How much lived experiences brought into advising on these systems that you have set up? Is there somebody in the lived experience that comes to the Rock County community event that happens, and Sunny as well? Was there much consultation with those with lived experience when you were, building this system?
Yeah, our EVDM group, when they were developing the mental health flag, we had an individual with lived experience as well as representatives from NAMI. So yes, and then we also in Rock County have some peer support specialist staff, so that when we're looking at policy changes in that, we try to get their input when it's relevant and part of their content that they can speak to.
Thanks, Betty. Sunny, what kind of lived experience?
Yeah, so I think from the police side is we work so closely with family and the people that are surrounding these individuals. So that is kind of who we're working with when we're developing game plans from like the police department side. I will not speak for Waukesha County in terms of what they do on their side because I don't know a whole lot about that. But for example, when I was talking about the flag for somebody having a shot order, that's what gets issued out to Waukesha Sheriff or to Sheriff's Department. So I'm not going to ask for lived experience on that. It's a court ordered pickup order. So we're just going to go ahead and do the flag in that instance, just to show kind of the difference.
Thanks, Sunny. Eliza, I saw you with your hand up.
Yeah, I feel so silly. I can't figure out how to raise my hand in the Zoom.
Just blurt it out. Go ahead.
Yeah. So I was just thinking, like, overall, in my experience, we were talking about this with the group participants, but a lot of our experience is like trying to get folks on a Chapter 51. And I just thinking about overall, like the whole revolving door issue with a lot of folks. And they're very ill, right? And they're allowed to be ill in the community, but they probably could benefit from a 51. They're just kind of like, they keep going back in, they're not getting help. They won't get help, but they have to be. So I always thought like an ED would be like the way to start that. So I'm curious, like, I don't know if we have this data, but I feel like a lot of folks that end up on Chapter 51s, it helps them to avoid having to go back into the hospital and avoid all those, which would save money. Can anybody speak to that?
Well, I'll start and then throw the ball to Betty and Sunny. The voluntary treatment is always preferable because if you're forced into treatment, it's traumatizing to you, and especially if it was a lengthy process and then you didn't really get help. What you learn from that is I'm not going to ask for help because it's not going to help me or my family member. So a lot of people learn from this dysfunctional process that we have right now. That said, there are ways to help. So, for instance, Minnesota has a new program where they have peer support specialists who will go out to somebody who looks like they're, like things are going downhill for them, and they will go out regularly and just kind of knock on their door and say, do you want to chat? I'm here to help you. And if the person refuses, then they go away, but then they'll come back, and so there's a more gentle approach. and a more kind of person-centered approach rather than having to call crisis. What we want to do is avoid the crisis if we possibly can.
Thank you. Yeah, I guess my experiences for like with a lot of folks, like I come from like an assertive community treatment background. So a lot of the folks that I've worked with like don't have the insight or the awareness. And they also, yes, of course, like who wants to force anybody or like, obviously the client should be, be able to be self-directed, but a lot of times they're not able to see like the long game, or they don't have a sense of the bigger picture. And so I think of like from a greater good perspective sometimes. And I've seen clients that have been on 51s that have done really well, not all the time. But yeah, and I also want to know too if there's anything like that in Illinois. I really would like, I have a couple of people that are in Illinois that I don't treat because I'm not licensed, but like friends and family and stuff that really are struggling with siblings or family members that have persistent mental illness, but is like undiagnosed and untreated, and they keep getting involved with the law and stuff like that. So if anybody has any Illinois resources, that would be helpful. If they could put them in the chat, I would appreciate that.
So, yeah, so we'll see. Okay. Somebody said we talked in our group that outcome tracking over 6 months would be helpful. For example, showing which steps result in more stability and quality of life. I know that Bette and Sunny, both Rock County and Waukesha County, do good data gathering. Bette, maybe you want to start about what kind of data gathering you're doing.
Yeah, so when somebody is on a Chapter 51 and we do have them on a commitment or settlement agreement, we do compliance monitoring, which also then tells us how they're doing. I don't have the numbers in front of me, like how many people, where there is that positive outcome. And we see it both ways. Sometimes it is that kind of key that gets somebody to engage in services and then they stay in services after. And then sometimes it's like Sita talked about, where then they don't want anything to do with us. Like we can't, and even if they engage in treatment, they don't want anything to do with crisis, like being part of their crisis plan or anything like that. Which within our system, we will do that too, where, I'll be honest, sometimes when there's somebody struggling, we'll send crisis out to try and engage with somebody so that their ACT team, their CSP team, maybe can preserve the relationship in a way and not be the bad guy. So that's another way we kind of collaborate internally for what's in the client's best interest. And I will say too, we talked about this in our group, but over the last 2-3 years, there's been a significant push from the public defender's office related to people not being on Chapter 51 commitments. The argument is that if somebody needs to be on commitment for 10 years, then they're untreatable and they should be under guardianship. I'm not saying I agree with that. I'm saying this is what's being argued in the courts. So about 2.5 years ago in Rock County, we had about 125 people on commitment. We currently have 24. And that isn't always in somebody's best interest. We've had individuals in our CSP program who were on long-term commitments by choice. They wanted that external control. They knew that kept them on their medications. And it's been quite painful to watch them slowly decompensate over these last 2 years, because we've had individuals who wanted to stipulate to their extension and their public defender argued against it. So it's a double-edged sword in many ways, but there's two sides to it.
Yeah, the whole question of civil liberties and personal preference, sometimes the person has a preference for something and that should be honored, whether or not the PD thinks it's civil liberties. Tom, I see you have your hand up.
Yeah, very quickly, the discussion obviously brings up the point that in looking at reforming Chapter 51 or improving it, that one of the discussions has to revolve around voluntary versus involuntary commitment. And I would just say that I think that you know, the stigma against involuntary commitment needs to be reexamined, because there are times when it's obviously necessary. And then the other part too seems to be that there needs to be a reexamination of what imminent danger is, and the ability to apply, I don't know, the fifth standard, or to me, what oftentimes happens is the person's right to treatment is denied. And that seems to be a part where um, needs to be sort of re-examined or looked at when we look at improving Chapter 51.
Yeah. Sunny, would you like to talk about what we learned about non-emergent petitions in Washington State?
Yeah, so Sita and I were trying to look at other states and what they're working on. And a non-emergent petition was an idea where, in the case that you don't have imminency and that kind of strict criteria, how do we, knowing that there's history with this person and kind of repeat, right, instances, still kind of scoop them up and get them safe without imminent criteria, basically. So there's some ideas that we have on how to maybe incorporate that in Wisconsin, but the argument has also been talked about that if we just used what we have, the standards that we have, to a more effective practice, that would also be great. A lot of people feel like we are not utilizing things correctly. So.
And there's a question in the chat for Betty. Do you have a 24/7 crisis response team in Rock County?
Okay, there. Yes, we do have 24/7. And we are, we fully staff it ourselves. But I often say when I'm doing trainings is, you know, in the overnight hours, I have one crisis worker for all of Rock County, and our population is about 165,000. But that's, you know, what we have and how it works. So I didn't see if there was other.
Thank you. Yeah, and yeah. Larry, I didn't know if you wanted to say any more about that.
No, just that I guess it brings up the point that if you've got connections, or if you have an abundance of resources that you can rely upon, you know, both with your mental health, substance abuse therapists, residential alternatives, full functional crisis team, and those good relationships and communication that I think that Sunny really emphasized in her presentation as key, it really can, you really can develop an effective system to provide the least restrictive level of care for individuals in a very humane way.
Yeah, thank you. And we did put the Washington State ideas in the handout, so take a look at them. There's several that follow along with how to use the 3rd through 5th standard. I see some questions in the chat about that. The non-imminent standards to more effect. Rick, go ahead.
Thanks, Sita. I just have been thinking about and reflecting on what Betty and Eliza said. One of the things that troubles me to my core is that Betty said they've taken people off of commitments and for 2 years watched them decline. That's wholly unacceptable. There's no aspect of personal rights that justifies watching somebody erode, become delusional, become homeless, become trafficked, all because they can't answer questions well or appreciate their situation well. Anosognosia. That's why they're on a guardianship or on a commitment. This notion that this is a civil rights, personal liberties issue is off the mark. And we need to push back. There is a better way, but there's a great cost doing it the way we're currently doing it.
Yeah, yeah. Alexandra, and then we're going to close.
I don't know how to ask a question with a little thing. How do you make the thing work? I'm very sorry.
Let's do Alexandra first.
Okay.
And, yeah.
Okay, so definitely to Rick's point, I mean, taking patients off commitment is just, yeah, unacceptable. As a psych NP and a provider of patients, like we work so hard to like help our patients and to maintain their stability and do all that. And for them to need a commitment, it takes so much to get on a commitment that for them to just take it away, especially if a patient's been stable for a long time, is just, I think it speaks to the stigma against mental health that we have. And I do think that to improve this and the care that patients are getting, I mean, it might sound too simplistic, but like I think there should be some sort of better education on like stigma and things like that for both like police and ED. To Sunny's point, she said, you know, it's the last thing that police want to go on. Like they have no desire to go on is kind of what I took from that. Whether that be, you know, just because of the time of the call or whatever, but it just speaks more to the stigma that's going on. And I used to work as a nurse before I was an NP in the emergency room, which working with those mental health patients was one of the reasons I became a provider, because we were seeing so much of a revolving door issue. And then we'd have issues where we'd want to chapter patients, you know, they'd be actually violent and we still couldn't get a chapter, all because, and this is anecdotally from police officers that I've talked to, you know, they're like, oh, I don't want to do the paper or something like that. So I think just more stigma education. And then my last thing was that I wonder if there's a way or a better way for outpatient providers to be involved in this process, more involved in this process, because, you know, we're treating them on a regular basis. And I feel like our recommendation should count for something, because there may be instances where, you know, they're just dysregulated and maybe they don't actually need a chapter, but somebody's, you know, concerned that they might. And then on the other end, we might be pushing and pushing and pushing for an emergency detention or a commitment, and we're being told no. So it's just, you know, as someone who went to school for this specifically to treat patients with mental illness, I just feel like maybe it would be good for us to be more involved in that process.
Thank you, Alexandra.
Sita, I know we're short on time, but really quick, I just want to respond to that. I want to correct this, because my brothers and sisters in law enforcement, I don't think that it's stigma. I think what's happening is from our point of view, we are the ones that get called to handle everything. So when the system is broken and not working, meaning when community supports and providers aren't willing to do their own home visits to check on their people, who do they call? They call officers. So it's a really complex, it's not just stigma. I don't want to send that message. I think we just are tired of being the only people supporting these folks, really.
Could I have 10 seconds? Thank you.
David, one second.
There's a huge problem. PRN. People go in, patient, Winnebago, other places, they immediately write psychotropics PRN. It's 51.61 sub 1 sub G sub 1. It has to be documented. Serious physical harm is imminent. These inpatient places are doing PRN, just giving them a shot of olanzapine all the time. They put PRN as soon as they come in the front door. That's got to stop.
Yeah. So thank you, David. We're going to close with that sense of urgency, because it's an urgent problem and a life-threatening problem for the individual, for their family, and community safety. And so we are gathering all of these practices. Thank you folks from the small groups for putting this stuff in the chat. Please also send it to Julia at info@mhapwisconsin.org. I think I also just put that in the chat. And then look on the MHAP website on the resources section. You'll see our collection of strategies to do this, to address this problem. MHAP has a criminal justice work group, which you are welcome to attend. Email Julia. We also have a data work group, and we have a Medicaid work group and a workforce work group, which you are welcome to attend. All meetings are virtual, and you are welcome. So thank you, everyone. Have a wonderful weekend. This has been a stimulating discussion, and you will all get the recording. Take care.
Thank you.
Be well.
Thank you. Enjoy your weekend.